And I'd like to introduce Dr. Chen. Dr. Chen is an attending physician at the Department of Oncology, National Taiwan University Hospital. Dr. Chen is an expert medical oncologist, clinician scientist in sarcoma, and comes today to share his perspectives on myths regarding management of EHE. Welcome, Dr. Chen.
So thank you, David. Let me just share my slides. All right. So, okay. So can you see my slides?
Yes, they're showing up wonderfully.
All right, good. Thank you. So, thank you, everyone. It's really good to be here, and it's really my first time to be invited to EHE 360. And so I'm a medical oncologist here in National Taiwan University Hospital. We also have a Center of Excellence for Sarcoma in our hospital, and I'm leading this team for serving our sarcoma patients. So today my talk will be the Mythbuster, so a medical oncologist view on the management of EHE. And I've discussed with Denise of how to really address some of the questions or the myths that we say that may have occurred in patient's journey, EHE patient's journey. So I'm going to use a few questions and one of my patient's experience as well to talk about this talk. So I'll be start with one of my patients of EHE. So this is a 37-year-old man who instantly found to have a liver tumor during his health examination. And during that, he had an MRI. And as you can see from the left-hand figure, this is the MRI figure, and my red arrows are showing these tumors. These are biopsy confirmed to be a EHE. And at when you first know there's a malignancy, you do a kind of staging, what we call to see how the cancer has, whether it has spread to other parts of the body. And what we found is that on the right-hand side, by a CT scan, this patient also have lung metastases. And this is what we have to tell the patients, that after our biopsy and our first screening, this patient already has what we call the stage 4 diagnosis. So my first myth is talking about, do EHE patients with stage 4 metastatic disease have similar prognosis or what we call survival to those of other type of metastatic soft tissue sarcoma? So I'm going to show a data. This is a data from the US SEER. It's the surveillance epidemiology and results, which is a data collecting all the cancer patients, their time of diagnosis, their staging, their treatment, and their outcome. So I'm comparing the survival outcome of EHE with patients with another type of vascular sarcoma, which commonly we call angiosarcoma. And this bar graph is showing the number of the proportion of the patients who have survived actually more than 24 months for this. And as you can see, the proportion of EHE patients, and these are all what we say stage 4 or metastatic patients. There's about 60% of patients within the stage 4 metastatic EHE patient survive more than 24 months. And as for angiosarcoma, actually goes down only to 20%. So compared with other vascular sarcomas, or even for other metastatic soft tissue sarcomas, EHE, you could say that it does have kind of better prognosis as compared with other metastatic soft tissue sarcomas. So I think this is at least the first kind of concept we want to discuss. And I think some people have asked these questions as well in the Q&A session, that we do see patients with stage 4 metastatic disease have very prolonged stable disease that we deem to really have a better prognosis. But the prognosis does vary. So sometimes we also see patients who comes with a lot of tumor burden and do progress quite fast. So this is a disease, I have to say, it's hard to capture its prognosis, but we do see sometimes that patient to have a better prognosis compared with other metastatic soft tissue sarcoma patients. And then the second myth is that do metastatic EHE patients need to be treated immediately? I think when everyone, patients that learned about the news that there is a stage 4 or metastatic EHE. Of course, the next step is I want to do something about it. However, because what I said about something about the prognosis of these metastatic EHEs, sometimes the treatment does not need to start immediately. So when we think of when to start a treatment for metastatic EHE patients, or when whether the patient had metastatic is just one part of it. We also go through a lot of what we call risk factors, or sometimes we call it prognostic factors. And these include the location of the tumor, whether the patient, the tumor is from pleural, lung, liver, and the patient's symptoms. Dr. Rubin has also mentioned about this. There's a pain, sometimes dyspnea or fatigue, and weight loss. And there's also feature of the EHE under microscope with other pathology features, like the mitosis rate, whether they have a tibia, pleomorphic, these kind of, and also the diagnosis of the fusion genes, and including the presence of metastatic disease. So when we decide whether to treat or not, we have to include all these features into a discussion. And then we'll come to a discussion with our patients, whether when we should start a treatment, or we do have some time for active surveillance to see how the cancer goes, because sometimes it is really to have a kind of slow or indolent disease going. So the clinical prognostic factors that we have mentioned, this is what we call kind of, and when we discuss in the medical terms, this is what we call a Kaplan-Meier curve. So in these figures, the x-axis is the time, and this is the month of time that kind of goes through. And the y-axis is the proportion of patients who has what we call an event. And in this, when we use it as a prognostic factor, an event means a patient died of the disease. So you can see that different locations has different kind of prognostic impact on the survival of EHE patients. Those who had more like a grave prognosis are patients with lung and bone, or patients with peritoneal metastases. The other kind of important factor is if we only divide patients who had pleura and those who doesn't have pleura, this is also a very important factor. So I think a lot of you may have heard from your doctor or from our friends or on the internet that EHE patients who does have a pleura, we have to be very careful, because this is something that we're really concerned sometimes when we see this. It may kind of be a signal that the tumor may have progress a little bit faster. We have to be careful. The third is whether this patient has more than one lesion in a single organ. So Dr. Rubin has talked about some of the basic terms that we use in the EHE, and this is one of these, what we call unifocal or multifocal. When we call it unifocal, that means within that single organ, there's only one lesion, one tumor within that. And we call it multifocal. It means that within, like instance, in the liver, they may have 2 or 3 lesions. So if you only have one lesion as compared with multiple, there's a difference within the prognosis. And not just these are the clinical things that we see from the imagings. There's also the clinical symptoms of patients quite important. Sorry. So this is a study from the Italian group, which they're very involved in the EHE study. So they had 67 EHE patients. And within this patient, whether the patient has like pain when they first have diagnosis of EHE, or whether they have effusions or have fluid within the pleural space or within the abdominal cavity, these all kind of represents the patient may have a worse prognosis, that we have to be careful. These tumors may progress faster. Even though when the pain was developed, not at first, but during the treatment, it still signals that they may have a change in the prognosis of these patients. And I think from our previous talk, we do know there are some biomarkers that may be related to this, but clinically, I think very importantly is the doctors know that to monitor the symptoms of the patients, so that we can catch that there's a change within the kind of the clinical course of these patients, and we should think of starting treatment with these symptoms. So overall, if we just think of a very big concept, when you first saw this patient, even for patients with metastatic EHE, we can think of whether to start with active surveillance. So this is not just like we're not treating this patient, although we're not starting the treatment, but we're actively following up these patients and to really see if there's a kind of change in the way the disease progress, or there's a change within the symptoms. Or we can think of when to have the start treatment initiated. So maybe there's a change in the symptoms, or even at an initial follow, when initially we see the patient, we decide that this is a very high tumor burden that we cannot wait. We do have to start treatment initiation. And it is through this regular clinical follow-up with these symptoms and image assessments, we adjust whether we should change the treatment and think of what the next step of treatment. And to have these all coming up, I think a lot, both previous speakers have emphasized the importance to have the multidisciplinary team to be involved, to have an experienced team to be involved in deciding when to treat and what to treat. And also, I would also say again that active surveillance could potentially avoid a lot of these over-treatment, where we could monitor the progress of EHE first before we start the treatment. Now, I've been talking a lot about treatment. So just the follow-up of our previous patient. So this 30-year-old man, he does have the liver and lung, and then he has his liver tumor resected, but the lung lesion weren't touched because they were quite small and they're quite deep. If we do the surgery, the patient may have to leave a lot of healthy lung to be resected as well. However, this is the power of active surveillance. After 4 years of active surveillance, this patient still has no tumor recurrence in his liver, and his lung tumors remain stable. So I think this is one of just my experience that start with the active surveillance, even for a patient with initially diagnosed with metastatic disease, is something that could be discussed with our patients. So I've been talking about a lot of treatments. However, if we think of, I think the third myth that I'm going to talk about is that whether there are available systemic treatments for EHE. I have to say, in the US, there is currently no approved treatment for EHE, but that doesn't mean there's no available treatment. I think Dr. Rubin has kind of mentioned some of the potential treatments, and I'll go through this in more in a clinical fashion to show what are the potentially available treatment for EHE patients. So before I go into some of the figures that I'm going to use, maybe there are some jargons that I would like to share with you. So first is what we call, sometimes we call what we call object response rate. So that means the tumor shrunk. And, you know, clinically, when we use the word object shrunk, we kind of expect that tumor has shrunk more than 30% of the previous size. So it's not just like shrinking by 5%, 3%. We're kind of really saying that the tumor after the treatment has shrunk quite a bit, more than 30%. So, and those proportion of these patients are what we call the object response rates. Although we do want to see response, another thing very important is what we say, how long can we control this disease? So a lot of times we use the term progression-free survival. So the patient is still alive and the tumor has not progressed. So the tumor has not really kind of progressed to the extent that we think you may have to change the treatment, or sometimes, although it has not shrunk, but the kind of tumor remain in that stable size. So that's why we kind of use a time interval to kill the progression-free survival. Of course, the last is the overall survival I have shown with some of the prognostic factor figures. So these are also a study from, globally. Our institution was also involved in this study. And globally, we had a lot of EHE patients and their treatments collected and how the efficacy was. These are some of the figures are EHE patients treated by chemotherapies. And because a lot of EHE patients are treated by sarcoma doctors, a lot of these chemotherapies are the regimens that would be used for our sarcoma patients. So that include what we call anthracycline-based chemotherapy, or in turn, because some of the other vascular sarcomas, they typically use paclitaxel as the one of regimens. So within patients treated with anthracycline-based chemotherapy, the median progression-free survival, the PFS, is about 5.5 months. And for paclitaxel chemotherapy, the median progression-free survival was around 2.8 months. That's around 3 months. And the median overall survival for the anthracycline-based chemotherapy was 14 months, and for paclitaxel was 18 months. So although the numbers in terms of PFS may not be as long, the length of duration as much as we could control, I have to say, in my personal experience, we have also seen some patients who occasionally respond to these treatments like paclitaxel. So although chemotherapy may not be like the first line treatment suggested by all the physicians treating EHE, sometimes this is one of the options we still would discuss with our patients. Now, going to the second treatment, I think others have talked about sirolimus, which we call is a mTOR inhibitor. So sirolimus is not only potentially used for EHE, it also has a lot of other clinical applications, including prevention of organ transplantation rejection and the coronary stents in our coronary artery of our heart. Sometimes it's coated on it. It's treatment and other lung benign disease we call lymphangial leiomyomatosis, and also a kind of sarcoma is called PEComa. So why does sirolimus, or why is sirolimus potentially possible for the treatment of EHE patients? We're still looking for the answer, but sirolimus targets called mTOR is a very important molecule within the kind of whole cancer pathway, which these are pathways that have been found to be activated in cancer cells that could drive the growth of cancer. So this pathway, I think this is just kind of hinting us that targeting this is something that we really could think of in treatment of EHE patients. However, we also want to see what are potentially benefits of using sirolimus. So also this again is from Dr. Stacchiotti. She's a friend of the EHE Foundation, been a while, and she has collected some data about 38 EHE patients treated with sirolimus. Among these, about 63% are women. The median age was 49 of these groups. All of them were metastatic patients, and 97% of them have confirmed has this specific fusion gene, the CAMTA1 fusion gene. And a lot of them has lung or liver involvement. Fewer of them have bone or effusions with their metastatic disease. And this is how they were treated. A lot of patients were started with 5 milligrams per day, or 3 milligrams per day, or 2 milligrams per day. So we kind of, when you use sirolimus treatment, we do have to monitor the drug level in the blood. So no matter like how you started, if you really want to have a rapid response, you do start with a higher dose. But you do have to monitor the level of sirolimus to make sure that you are at the correct level. There are some patients having some hematologic toxicity, so we call like neutropenia. That means decrease a kind of the white blood cells that is kind of have to fight the pathogens or the bacteria as the first line. There are also some patients may have thrombocytopenia, is the decrease of platelets. Other non-hematologic malignancies include the mouth sores, we call it mucositis, or there's patients who have cholesterolemia, so the lipid within your blood may have a little bit increase when you're using these kind of agents. But however, most of these are manageable, so we do think that the treatment of sirolimus, the side effects are more tolerable and manageable. Here are some of the data that we trying to show its efficacy. So out of these 37 patients who are evaluable for sirolimus efficacy, 10% has a response rate. And if we use clinical benefit rate, that's including those who has responded to the treatment and those who had stable disease for more than 16 months, that adds up to 65%. And this is just one of the patients with liver EHE kind of responding. The dark area within the scan, this is the liver is kind of, you can see that the dark area is getting smaller and smaller within the 18 months treatment period. So there's definitely some patients who responded quite well to the treatment of sirolimus. However, this is a retrospective study. So the median PFS was 30 months and the median OS was 18 months. So the progression-free survival was 30 months. So 50% of these patients had at least 30 months of sirolimus treatment. However, I said this is a retrospective study, and this is a single-arm study. So there are a lot of agencies who do require that you do have to have what we call prospective monitoring. So you have to be at the start, when you start treatment, to carefully monitor how the disease has progressed. And I think the Italian group and the EHE Foundation, and also and other EHE Foundation in Europe, has been discussing with the EMA, the European Medical Agency, as to how to really have a clinical trial or study design to show the efficacy of sirolimus in treatment for advanced EHE patients. Next, besides EHE, there are some patients, there are some reports using what we call anti-angiogenic agents. So as Dr. Rubin has mentioned, EHE is a disease from the vessels or the vessels endothelial cells. And so what we thought that maybe when we target using an agent that we target the development of the vessels, maybe that could possibly work for these cancer types. So there are some of the studies using anti-angiogenic agents, including sorafenib, bevacizumab, or pazopanib to treat EHE patients. So pazopanib is also approved globally for metastatic soft tissue sarcomas, including a lot of vascular cancers. But I think within this, what we saw is that the median PFS is sometimes have a wide range. And I think for most commonly, even for pazopanib, which is most commonly used anti-angiogenic agent in soft tissue sarcoma, it really doesn't have that kind of the kind of long-term control effect that we expected. And my explanation for these are what are results so different, this quite heterogeneous nature of EHE. As I said, the disease itself at the start may vary, and during this progress, sometimes it can change differently as well. And whether these studies, a lot of these studies done in the earlier time, whether require before entering this clinical trial to have patients to really have progression before treatment, that may be different, because if you kind of enroll a patient into a new drug before the patient actually has confirmed tumor progression, you may be just monitoring the indolent disease of this patient rather than seeing the efficacy of the true whether this drug had efficacy or not. So I think this is something very important when we're thinking, asking EHE patients to be enrolled into a prospective clinical trial to really have patients who has shown, progressive disease based on their scans. And I think in these studies, there's also no clear mention what these patients were started as a first-line treatment or later-line treatment. And I think the last drug that we're going to talk about is trametinib. I think Dr. Rubin has also talked about this as well. So the fusion genes that we know is very important and very important for diagnosis for HE. Actually, in their Dr. Rubin's model, they found that they secrete a kind of molecule called CTGF. And this goes into stimulating the cancer cell through what we call a pathway, the RAS-MEK pathway. So if we have the drug that could target the MEK molecule, maybe we can see some efficacy. And this is Dr. Shuzi's clinical trial, which was published in Clinical Cancer Research this year. They've had a single-arm study testing the efficacy of trametinib in advanced EHE patients. They had 42 patients across America. And within this, there's slightly higher female patients. The median age of 52. There are a lot of patients had lung provide involvement and also patients with liver involvement as the majority of these patients. And as you can see from the slides, this is what we call the waterfall plot. This is showing that the 0 is the tumor where the size is started. And if it goes down, it means that the tumor kind of have certain tumor shrinkage. If it goes up, has a slightly higher, kind of larger increase in tumor size. And as you can see that there are about 10% of patients, so to be exact, 9.5% of patients had at least tumor shrinkage more than 30%. So that's why we call the ORR, the objective response rate I had mentioned. And the median progression-free survival was 8.3 months. The star means that the patient actually reported improvement of the symptoms. We have kind of said that patient symptom is also a very important prognostic factor in our management of EHE patient. So sometimes, even though the tumor did not reach the extent of tumor shrinkage more than 30%, did not reach a response, but we can see that patient at least has improved symptoms. And clinically, I think that improving symptoms is very important for a patient as well. And I think just like Dr. Rubin said, he's the central pathologist of reading all these patients. Interestingly, in this cohort, there are also EHE patients who either was not able to provide enough samples, or when they tested, they did not have the common, what we call WTR1 CAMTAR1 fusion gene. But also because of the histology diagnosis of EHE, these patients were also included in the analysis, just shown on the brown waterfall plot. So I think overall, I have spent some time talking about some of the myths and some of the treatment and some of our thoughts on discussing with the treatment with our patients. So I have to say EHE does have a very prognosis, but even for those who have metastatic disease, these patients could have a good prognosis. And systemic treatments may not be always immediately necessary for metastatic EHE patients. Just like I show in my patients, that active surveillance could be considered. Other potential systemic treatments when you really need to start treatment include the mTOR inhibitor, sirolimus, sometimes chemotherapy, anti-angiogenic agents, or like we said, trametinib in the study. I think we could never emphasize enough the importance of having a multidisciplinary team and experienced sarcoma expression in the treatment journey of our EHE patient. And this is really, I want to thank the EHE Foundation for inviting us. This is our team at our home at NTUH. I'm happy to answer some questions. Thank you.
Yeah, thank you so much. And for everyone in attendance, Dr. Chen has donated a very late time to us. He's in Taiwan and it's very late at night. So thank you for your consideration. One question that came up, actually your talk prompted quite a few questions. And if you have the time and interest, maybe look at those questions and you can answer them offline there. But one that popped out early was, is EHE a forever disease? And specifically, is it a disease where people have cleared it and it's gone away?
Yeah, I think, there are anecdotes where that EHE did kind of resolute or gone away, but I have to be honest, like I personally haven't seen a EHE patient, especially for those with metastatic disease, really have all the tumor kind of disappeared. But there are sometimes, even for metastatic disease patients, they are still could consider to have either local ablative therapy or have surgery to remove all these lesions. So we still have but for these patients, even removing all these lesions, we still have to be careful. I still would recommend this patient to continue their follow-up. I would still, continue to follow up this patient just to make sure that when I see it comes back, I know that we have to discuss whether we should start treatment or at least we can continue with the active surveillance thing to ongoing.
Excellent. Thank you again so much for your time.